Okay, hello everyone, and thank you for joining us on this episode of the Akkad and Koka Report. I'm Michel Akkad in San Francisco with my co-host Anish Koka in Philadelphia. For an increasing number of Americans today, a single-payer system seems to be the only conceivable next step in the cataclysmic and ruinous history of our healthcare system. Likewise, in the aftermath of the Affordable Care Act and the failed attempts to reform the reform, a growing numbers of physicians are either resigned to the inevitability of a single-payer system, or are looking forward to its realization. Our guest today certainly belongs to the latter category. Adam Gaffney holds an MD degree from New York University and a master's in public health from Harvard. He currently practices pulmonary and critical care medicine in Boston and holds a position of instructor at Harvard Medical School. But Dr. Gaffney is known to many nationally and internationally as a physician activist who has been campaigning on behalf of a single-payer system for many years, long before it was acceptable or even fashionable to do so. He sits on the board of directors of PNHP, the Physicians for a National Health Program organization, which is the most important American medical organization advocating for a single-payer system. And he serves as a secretary for that organization, and I believe he is president-elect. He is immensely prolific and talented as a writer whose clear and direct prose in support of progressive causes and universal healthcare appears regularly in prominent venues such as The New Republic, Salon, Jacobin Magazine, and The Nation, but also in mainstream media such as The Guardian, The Washington Post, and U.S. News and World Report. He has been featured on NPR, NBC, and the BBC World Service, among other outlets. And he recently produced his first book entitled To Heal Humankind, The Right to Healthcare, or The Right to Health in History, which was published by Routledge in 2017. You can find him on his website at theprogressivephysician.net. Adam, welcome to the show.
Thank you so much for having me.
We're delighted to have you, Adam. So I'm going to make it open-ended. Why don't you give us the case? I'm sure you've practiced your elevator pitch. Give us the case for a single-payer system in the United States.
I've been working on it all morning. So the pitch for a single-payer system. Healthcare is something that we all need, either in the present or in the future. It is something we all rely on. It is something that is universally required. It is a good that is necessary for life. It is necessary for a good life in many cases. And it can improve not only the quantity of the years we have on this planet, but the quality of our time. It is something that is best provided universally and equitably, and that history shows works best when delivered as a public good, not as a private commodity. So I think once you concede an ethical framework in which healthcare should be a right, once you concede the framework that healthcare is something that everybody should have access to on an equal playing field, then you quickly come to the realization that there's no real way to achieve those goals, to achieve those aims, without having a public universal system. And whether that's a national health service, a national health insurance, which is more what we promote, there's sort of benefits and drawbacks of each. But the larger picture is that if you want everybody to have an equal right to healthcare, you have to provide an equal right of healthcare. And that has to be through public provision, through a public program. And for a variety of reasons, we believe that single-payer financing is the best way to go about doing that. And so that's why for many years, national health insurance has been the favored solution for the healthcare woes of developed societies, and why we're continuing that fight today and think that it actually is something that is winnable in the not so distant future.
Okay, so the broad outline of your proposal, because we're going to push back a little bit on some of the points that you've made, but I want to continue to give you a chance to outline the idea. It would be a system where the government pays for insurance, but it's still delivered privately. I mean, you're not going to nationalize the hospitals or make doctors employees, or what's the overall framework?
Right. I mean, that's the difference between sort of a national health insurance system like in Canada versus a national health service like in the United Kingdom. I mean, the reality is it's not quite as stark as that. But yes, the national health insurance system, as in Canada, everybody is insured through the government, but it is not, the government does not own all the hospitals or employ all the physicians directly. So more akin to Medicare to some extent. The National Health Service, as I'm sure you're aware, the government actually owns the hospitals. Although in reality, general practitioners are sort of in between. So we envision something closer to the Canadian system, with a role for public oversight when you're talking about large monopolistic health systems. But overall, we're talking about something more akin to the Canadian system, national health insurance. Doctors would still, for the most part, be private, but would be paid through the public system. Similarly, we're not proposing the nationalization of all the country's hospitals either. As in the Veterans Affairs Administration is an example of a fully socialized health system. We're talking about something closer to the Canadian model.
Anish.
So when you say healthcare, Adam, what do you mean by healthcare? Like what exactly? Can you help define what it is when you say that we should provide healthcare as a right? So what healthcare? What is healthcare?
Well, I mean, we can sort of list the sorts of healthcare services. So doctors' visits, ambulatory care with physicians and other healthcare professionals, inpatient care, prescription drugs, rehabilitative services, surgical services.
I see. So I ask because the problem is that when you do that, you run the risk of creating lots of disease. Correct? Meaning we have guidelines that in one fell swoop makes half the country hypertensive, right? And now we say, well, everyone needs healthcare. So then, half the population needs to see a doctor to get their systolic pressure of 125 treated. So it gets to this idea, that if that's a right, if having a systolic pressure of 130 and being seen by a physician is a right, then getting to that other tier, which I know you've talked about in many of your excellent articles, getting that other layer of how do we pay for this? Because you're talking about paying for this through taxation, obviously, correct?
Mm-hmm.
And so it seems to create a kind of unsustainable path, which, by the way, is what seems like all national health programs, wherever they are around the world, struggle with. Because as soon as you do that, you suddenly have folks trying to, if you will, game the system, or even if they're not aware they're gaming the system, they're trying to do good for all, and suddenly 70% of the population needs to be paid for, and you have some massive budgetary mess, and you have massive deficits, and all of a sudden we keep trying to raise taxes, and everyone is unhappy, and you get some backlash. So is that something you're wary of, or is that something that you think? Am I right to have that concern that this sets up a unsustainable problem moving forward?
Well, I mean, I think there's a lot wrapped into that question. First, I mean, simply from a perspective of national health spending, okay, we know that we're not doing good in that metric in the United States. So 17% of U.S. GDP goes for healthcare, and it's much lower in other countries, closer to 10% in many countries. And some countries may be spending not enough on healthcare. I think the UK probably should be spending somewhat more. But the reality is that the private sector does a worse job of controlling national health expenditures than do public systems. I think that's just empirically true. Now, in terms of budget constraints, there's always going to be a push and a pull in terms of how much money we want to spend through taxes on healthcare. I think that polling shows that public programs are actually fairly popular, and that programs like Medicare and Medicaid are actually quite popular, and that people are willing to pay taxes for those sorts of programs, particularly programs that are universal, that give everybody, regardless of income, benefits from things like Social Security, Medicare. You see very high supports for this program, for those sorts of programs. So I am not that worried that this is going to just continue to grow and become a sort of unsustainable drag on the budget. If anything, I think the value of having a public system is that it creates some accountability, and and it forces you to make some choices and to allocate resources efficiently. But again, just to go back to the empiric focus, which I think is most important, we know that national health expenditures in the United States are the highest in the world, and that public systems do a better job. So in terms of the national health expenditure metric, single payer would clearly do better. And even a recent libertarian, report found that in terms of national health expenditures, they estimated that it would be better under single payer.
So Adam, I had a patient I just saw on Thursday or Friday who was a retired American physician who was vacationing in Greece. And she had a bad fall down some steps, fractured both her right arm and left shoulder, was badly injured. Showed up at a ER in Greece, and 2 days later she's in my clinic. And I asked her, what happened? Why did you not stay in Greece to get this fixed? She looked to be a lot of pain. She was getting surgery done the following day in the United States. And she said, Dr. Koka, I walked in, and the emergency room is the size of this room that we're sitting in right now. I had zero confidence in any of the physicians I saw. I was supposed to get some antibiotics, and they sent me to some local pharmacy. And they had no timetable they could give me for when I could get surgery. And with what I saw when I walked into that hospital, I had no confidence. I didn't want surgery there. So she got on a plane with her cast and stuff, and came here, and is now being operated for the following day in some nice hospital over here. Me and Michelle talk frequently about why it is we spend 17% of GDP on healthcare, and how we are vastly inefficient in terms of allocating resources, and we lay the blame at that this isn't really any more close to the free market. It's crony capitalism, and there's lots of rent seekers in this space, and we could definitely be much more efficient than what we're doing now. The concern is that the anecdote that I'm describing is not necessarily is an anecdote that is a very similar one that happens in most nationalized health service models. Meaning the only way, and I spoke to a Greek physician afterwards to talk to him. I was like, well, how does this happen? He's like, well, if she had known to go to a private hospital and paid for it, she would have gotten same day care or next day care. So yes, we are vastly inefficient. Do you necessarily think that we're going to be why should we, does it make sense to recreate the mistakes of these other nationalized health service models around the globe? Meaning, obviously, that's the care that she's a patient, and she's saying that this was utterly inadequate. I'm not going to stand for this. I'm leaving the country, getting on a plane in pain with casts in multiple places to come here so she can get care, the next day. Meaning, so she didn't pay a single cent for the care she received in Greece, but yet she's here trying to get care. So the concern is that that's the trade-off that isn't frequently highlighted in terms of what it is you're getting for these vast amount of dollars that we inefficiently spend in the United States.
Right. I mean, there's several issues there. First, focusing on Greece for a minute, Greece does have a public healthcare system, but it has been very undermined in the last decade by austerity. I'm not an expert in the Greek healthcare system, but I've written a little bit about this, about Europe in general, that as part of this sort of post-Great Recession effort to reduce public spending, sort of enforced by the IMF and whatnot, that there was major reductions in public health spending. In Greece in particular, a lot has been written about some of the detrimental effects that's how the healthcare system there. So certainly you can make a public system not work well if you don't fund it at sufficient levels. Now, that even if we accept that the Greek system has some shortcomings, you could equally tell a story of a person in the United States who gets no care because they're uninsured, or declines to get care because they can't afford it, because they don't, they have a modest income and a $4,000 deductible, which is becoming the norm. So you could tell other anecdotes here. I'm not discounting her story. I'm not.
Right.
I'm just saying.
But the person who comes in with a fracture into the ER in our system, and I have a list of 35 people in the hospital.
Yeah.
Some 15-20% of them don't have health insurance, and some of them are ill or very ill and have acute issues that obviously are dealt with and will be dealt with in most developed countries.
Mm-hmm.
But some of them have issues that they need a repair the next day. They're admitted to get a repair the next day,
right.
And there's enough fat in the system that we just do it, right? So there isn't. My point is, there isn't uninsured or not, that woman, right, coming to the ER here, with a fracture in a shoulder or whatever, gets fixed the next day, and yes, we swallow the cost, and yes, and that's another issue in terms of, I think, how we do that. But my point is, as sitting here right now in the system we have today, this lady here, insurance or not, is getting taken care of next day or 2 days from now. I see all the time patients with, I or not emergencies. I mean, what is an eye emergency? But they don't have insurance. I see them gratis. The eye hospital down the street operates on them for whatever. Meaning, that's not
the typical. I mean, so look, there's charitable healthcare provisions in societies going back to ancient times, right? Nothing. But that is not necessarily the typical experience. Many people go to the emergency room because they get hit by a car and they get a massive bill from the hospital 2 weeks later, and that can make them go bankrupt. And then putting aside, now it's hard to avoid the hospital if you get hit by a car or something like that. But people put things off when they're worried about the payment. They may, there was one study that found that people having chest pain because of an acute myocardial infarction actually delay, going to the hospital if they have financial strain. So there's no question that, particularly for less emergent, well, even for some emergencies, people will still avoid the emergency room. But even if they do end up in the emergency room, it's not a great system if it makes you bankrupt, or if you get a massive bill.
Sure. But Adam, can we agree that if we tomorrow instead of spending 17% of our GDP on healthcare, we spend 11%, right? And we have.
I don't want to do that, for the record, though. I don't want to reduce our spending from 17% to 11%.
Oh, I see. Okay.
Yeah, I would actually be fine with continuing to spending
what we spend.
Yes,
I see.
I think it's unrealistic to claim that we're going to reduce GDP, healthcare spending, even if you wanted to. I don't think you can just slice 6% of the national economy off with one fell swoop just by passing a law. I don't think it's realistic, and I don't think it would be a good idea.
So you don't think we will save money overall by moving to the system? So you think actually we could be spending more money? And I mean, so you don't think we're actually going to? I mean, in a Medicare you're talking about Medicare for all kind of, but in that system.
Yep.
Yeah, improve. Yeah, you don't think we'll be saving any more money?
So this is an area of sort of great controversy among people on my side of the fence. I don't know for sure exactly what we'd be spending, and it would be ridiculous if I claimed that I did. I think there may be small decreases in what we're talking in terms of national health expenditures, maybe somewhat larger than small, but no, I do not expect us to reduce our national health spending to the level of Canada, the UK, or these other countries. I don't think you could do that without disrupting care provision. What I envision is, in some ways, this project is very, ambitious, obviously, but in some ways, it can be seen as slightly more modest in that, we keep sort of current ways of paying doctors sort of similar. We, don't dramatically change provider reimbursement. We make savings on the administrative side. We make savings on the drug side, and we redirect those savings to eliminate uninsurance and eliminate copays and deductibles. So it's ambitious, but not so ambitious as slicing off, 5% of the U.S. economy, which I just don't think is good or possible.
Yeah, let me go back. I think I agree that, trying to debate on projections of how the spending is going to go is likely to, not to be very fertile ground for the conversation, because, how often have projections, been accurate, across the board. I want to go back to something that you said earlier, where you said that, healthcare is we want healthcare to be as universal as possible. And you said that history has shown that for this to happen, it's much better when it's provided publicly than privately. But I question that, and I question it. Health insurance only exists by virtue of government intervention. Actually, health insurance is not, nowhere in the world is it a product of the free market. The governments, especially if we take, the example of all the Western European countries, it's always clearly been a big government program. Mm-hmm. But even in the U.S., even the early iterations of private plans and insurance in the 1930s and 40s were facilitated by state level legislation that made the emergence of health insurance possible, because otherwise traditional insurance companies, life insurance companies, were very reluctant to insure health for the reasons that Anish mentioned. I mean, this question of if you start providing health insurance, you're going to immediately boost utilization. Now, for you, utilization is not necessarily a bad thing. It may be actually a good thing that utilization be boosted if people, needlessly ration their own care and avoid going to the hospital because they have a heart attack and so forth, or chest pain and that sort of thing. But at the same time, the provision of health insurance by boosting demand, and I think it's clear that it's been boosting demand, raises, at least in the US, the way the system is structured, raises the price of healthcare tremendously. So the cost of healthcare has risen dramatically each time there's been a big government intervention to achieve some kind of enhancement in access to care. So that's been the case when employer-based insurance was promoted by legislation in the 1940s. So there was a big increase in the cost of healthcare because now all employed people had access to care. They could go to the hospital and go to the doctor and utilize resources that made the prices go up, and that really hurt the people that did not have access to employer-based insurance, which was the older folks and the poor folks, And in response to that, then the government said, well, let's have Medicare and Medicaid. But then soon after Medicare and Medicaid were implemented, then you had a huge increase in the cost of healthcare. And after that, then you had schemes of rationing, the HMO Act and whatnot. So successive schemes of rationing. So in a way, it's a vicious cycle, because when you promote utilization of care, you can on the surface say, well, immediately we see, look, people have health insurance, they use it, it's a good thing. But at the same time, it makes it unaffordable to people who don't have access to the system. And your idea is that, well, let's provide it for everybody, right? In a way, you say, let's provide it for everybody. Mm-hmm. But then if you provide it, why is it just to provide healthcare to somebody who's otherwise why should the community subsidize a very rich person, who would otherwise, they
wouldn't be.
You'd subsidize you have rich people now who, are getting, liver transplants because they've been, drinking, all their lives, and they're getting their second one and their third one, and they're getting it, and that's at the cost of, it costs the community money. Resources are being put in subsidizing care for rich people. So the question of justice, which was the initial impetus for this, the question of justice doesn't make sense when you're subsidizing, the rich as well as supposedly the poor, when in fact, in practice, the rich always get more out of the system than the poor do. The poor always get shortchanged in the system. And it's true here in the current system, which is very unfair. I agree with you. But it's also true in other countries like Canada. Politicians in Canada frequently come to the US at taxpayers' expense to get their expensive surgeries that would take them much too long to get, in their own system. So they come here to get it and so forth. So, the question of justice, I find it a little bit, problematic, because it ends up being a huge subsidies to rich patients, and it ends up being a huge subsidies to the medical industry. It turns out that providing insurance guarantees income to doctors, to hospitals, and so forth, and puts a lot of money in the pocket of people, and it maybe trickles down eventually to some patients, but I find it difficult, as opposed to a system where you say, listen, food is very necessary to a lot of, to survival, to health. We don't have a national food program, right? Food is still, for the most part, a market good that we allow people to purchase out of their own goods. And then there's maybe a safety net for people who are very poor, and you can debate again the value of that or whatnot. So why not, in your case, if you think that healthcare is a right, and why not provide it as a safety net to poor people, and why not let the rich people pay for it and ration their own care, and not by not giving them health insurance, by not subsidizing health insurance, you remove this huge drive for medical cost inflation, which ends up hurting the poor or hurting others. Why not just adopt the safety net program, where you say the rich people can afford their own health care, and we'll have something for the poor people?
So several points I'd make in response to that. First, yes, I do think boosting utilization is good. I mean, that's what we do. We provide medical care. If utilization wasn't useful, then what are we in the business of doing? So I do think that boosting the right kind of utilization is a good thing. I don't think that Americans use too much healthcare. From what I understand, from the numbers I've seen, doctor visits per capita, hospitalizations per capita, et cetera, by these metrics, we don't use more healthcare than other countries. And I've never heard a good argument that we should be using less healthcare as a nation. Yes, you can say we should be using, less low value and so on and so forth. But at the end of the day, in terms of aggregate healthcare use, we're not using too much healthcare. So if your argument is that insurance has boosted healthcare spending, and healthcare spending can be broken down into quantity and price, clearly the boost in quantity hasn't been a problem because we're not using too much healthcare. That's why I don't promote reducing utilization as a way to produce savings, as many other people do. Because I don't think there's much. Yes, you can reduce, I don't know, maybe proton beam therapy. I don't know too much about it, but apparently that's always invoked as sort of the low value care. But overall, I don't think that we're going to actually save money by trying to use less healthcare as a nation. Now, if that's the case, then your point that insurance increases healthcare spending comes down to price, because spending is only quantity and price. So if the problem is that that insurance is driving up the price of healthcare, and why that would be, we can talk about, then you regulate the price and problem solved. Now, insofar as Medicare failed to do that, or failed to sort of control new capital expenditures and so on and so forth, then there may have been better ways to do it. But insurance in and of itself should have a modest boost in terms of the utilization of care that I think is overall appropriate. It'd be very different if we had a national beer program where everybody got universal access to beer. Yes, there's a moral hazard there that you would want more, assuming that's a beverage you enjoy. But fortunately, healthcare is not one of those things, because I think by and large, people actually certainly don't like going to the ICU where I work. But I think more broadly speaking, you have to drag people to the doctor very, very often. There's some hypochondriacs and that sort of thing, but it's not, the idea of the moral hazard in healthcare, I think, is overplayed. People hate taking drugs. They hate, it's not an enjoyable sort of experience. It's good to.
I don't know. I think I push back. I think it's underplayed. I think it's both. And it's, you clearly have people who, I think that, the hypochondriac case is limited, but it can be boosted in a way that is not apparent as somebody being really eager. It's not the case of the hypochondriac, but it's the case that, well, okay, if getting, this, I'm uncertain, there may be this nodule, I'm really not quite sure, and it costs me nothing, then yes, I'll get the big CT scan and I'll get the MRI, or if it doesn't cost me anything, And I think that's been proven.
But that's the doctor's role to recommend, to say, I recommend that this is going to be useful for your health and not useful to your health. I mean, are there some people, if the doctor said, look, this is a 1 millimeter nodule, it has a 1 in a billion chance of being a cancer, and you're more likely to get a harmful, biopsy by getting this CAT scan than to be actually have your health improved, I think most people would say, oh, well then let's just, wait and see. If you make it a total free marketplace, everybody's just picking and choosing, maybe I'll get an MRI of my brain to, my single payer advocacy has been flagging recently. So let's see what's going on. Maybe that, then I would. But I think that, if you look at the Rand health insurance experiment, there is a limited increase in utilization when you make healthcare free.
Right, but the Oregon Medicaid experiment suggests that actually the moral hazard component is greater than people had.
What was it, 10 to 20% increased utilization? I think.
All these are imperfect. It's we can't really have a rigorous control trial. But I think it stands to reason that if something is. What really controls and what really gives information is a freely set price. A freely set price gives people a sense of the value of goods and services, and that's really the use of in the free market, the use of prices, right? So it's not that you have price that can be arbitrary and you can set them wherever you want. A price reflects people's demands, competing demands for various goods and services, and so when you let prices float freely in a free market, then the price becomes a signal that's important for the doctor. I mean, how is the doctor going to make a decision on behalf of a patient to say, yes, this is worthwhile for you to get this test or to get this procedure or whatnot, if the price doesn't have any bearing, doesn't carry its signaling function, which it doesn't in systems where government is so involved either in setting prices or subsidizing consumption or doing X, Y, and Z. So then
I don't think doctors should incorporate the price in the medical decision making. I think that's the road to class-based medicine. If I start just making decisions about what I'm going to prescribe based on how much it costs that person, I don't practice that way. I don't say I'm going to use a generic antibiotic, even if a brand name is better, because it's going to save the society money or something like that, or the person money. Maybe in some cases, has the way I practice ever resulted in a bill for somebody that is and that's horrible. But once you go down the road of trying to factor price into your medical recommendations, I think that's a very fraught.
Right, but then if you don't, then what will happen is that somebody will, which what you mentioned earlier, is that Medicare-for-All will set prices. Then you will have the government setting prices. Because obviously healthcare is a scared resource. I mean, we all agree that it has to be limited. It has to be rationed. Right? It cannot be. You cannot just open the spigot and say, it's not a scarce resource because people don't like to go to the doctor. It is a scarce resource, and people will overuse the lower you make the price, the more it'll be overused, and that's true in healthcare, just like it is in everything else. Even though healthcare may be unpleasant, but on the other hand, healthcare offers the promise of living longer. People like living longer, and so they will buy more healthcare. Right? They will purchase more healthcare just because it offers the promise of living longer, which is a good that most people want.
I think a lot of, yes, but this is the difference with healthcare and other goods, okay? Again, this would apply if you were talking about real estate, houses, vacations to, Greece. People want healthcare to the extent that doctors tell them it's useful in most cases, okay? So it is largely induced demand that is now that economists use that in a different term. I'm using it in a non-judgmental term. I think we do induce demand. I think we should induce demand by meaning that we tell somebody we think this would be good for you, and I recommend it. Also, I think you're right. It is a scarce resource. I'm not claiming that we can, we're currently right now, U.S. doctors probably provide a little over 1 billion doctor visits a year. 1.1 billion doctor visits a year. Can that suddenly become 2 billion? I don't think so, unless you would have shortened doctor visits or double the number of doctors. So I think that single payer will have distributional consequences in terms of who gets those visits, who gets doctor visits. I don't think it will radically change the number of doctor visits because I don't think, because I think it's largely a supply limited phenomenon. Similarly, hospitalization. There's only so many hospital beds in the country. You can't triple the number of hospital days. It's not possible. Now, if you have an open-ended system where you don't control capital and you create an open-ended system where anybody can build more hospital beds or anybody can, build more CT scans, then you can envision a system of along the lines of, I will concede that in a system with unlimited capital expenditure and no constraints on supplies, no constraints on who can become a doctor, that you could imagine a spiraling cost scenario and that you do need those controls.
So, no, because if they're competing with one another, then the prices will fall. I mean, if it's truly a free system, if you open 10 MRI facilities, they're going to have to compete on price, and the prices will fall.
Say's
Just
law,
like, there's plenty of
Medicare.
Say's law, properly understood, not the way the Keynesian have completely corrupted it. But if you have,
no, I don't believe in Say's law except for in healthcare. I think that supply does create its own demand in healthcare.
Right.
I think that's true. It's Romer's law. Milton Romer, leftist health policy thinker. A hospital bed built is a hospital bed filled. I may be mangling the quote slightly, but that's more or less accurate. I think there's some truth to that. I mean, it's not unlimited, but I think there's some truth to it.
Correct, but it's not necessarily good. Again, I don't know.
No, that's why you have to control the number of hospital beds.
So you're gonna put a cap on the hospital beds, but how can you manage how do central planners know exactly how many beds are needed and don't overbuild or underbuild, or all that knowledge escapes the field of view of the central planner. The central planner doesn't really have a good idea of how many beds. All you can do is base it on how many beds were used last year, but we're starting from a system where actually you disagree with the notion that there's overutilization. Other people say that there's tons of utilization. We really have no idea right now. It's a complete mess. I think what it is, there's a misutilization. There are many people who are overutilizing healthcare and many people who are not having any access to healthcare. There's a complete mismatch of who needs and who doesn't need. And the best way to equilibrate that and to make it fair is for local communities and local people to figure out for themselves who really needs it most, who can afford it, by what criterion they're going to use it, relative to other services that they could be using and so forth, and let that settle down. But if you have something that will, manage 330 million Americans, the supply of goods and services for 330 million of Americans, I can't imagine that it wouldn't be perpetuating the misallocation of goods and resources.
Adam, I think it comes down, Adam, to whether or not we can have some omniscient panel or group of folks somewhere who are able to allocate resources in the most efficient manner possible. So we had, a couple of weeks ago, we had a, just to show, all these first order intentions and feelings and are fantastic, but they always seem to run aground when you take them further. So, for instance, the certificate of need laws you bring. So, number one, let me summarize what you just said was that yes, you're in support of a national payer for all, insurance for all, correct? But you must couple that with some type of cap, some type of a cap on supply. Of hospital beds, of how many doctors there can be in one area, of how many MRIs there can be, how many proton pump, blah, 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 correct? So
I don't know about the doctor part, but the other part, yes.
Okay, yeah. In some way, you have to control supply if you're going to regulate price and have insurance.
And we already control supply of doctors through resident.
Right. Yeah, true, right. I'll give you, we had a doctor on named Gajendra Singh a few weeks ago. He is a transplant surgeon working down in North Carolina. And he went to get an ultrasound for himself and he was stuck with he got a $5,000 bill. He said, what the heck? He has some high deductible plan. He's like, what the heck? Why are they charging this much money for an ultrasound? And, I know what an ultrasound tech machine costs. I know what an ultrasound tech costs. I know how much it is to read, how much time it takes for radiologists to read. this is utterly absurd and ridiculous, right? So he opened up his own imaging center, right? He opened up his own imaging center, and he was cash only, and his rates were a fraction of what the hospitals around the area were offering, right? He tried to offer MRIs, and he was told that you cannot offer MRIs. You can't offer MRIs because the Certificate of Need law says that, there's some central group that decides how many MRIs can be in that area. Now, clearly, there is a local need for MRIs at a fraction of the cost of whatever massive amount that the local folks are charging. Yet, you have some layer of bureaucrats who are saying, nope, you don't need MRIs. And the problem is, even if the bureaucrats were well-intentioned, well-meaning, and were somehow insulated, they're not insulated, right? They're able to be lobbied, right? So you have hospitals that are the biggest employers, right, in any given county. And so they have tremendous outsized influence with politicians. And the politicians then exert influence on that regulatory layer below them to then say, nope, we don't need any more MRI machines, right? So he's actually filed a lawsuit against the governor and the state, arguing that this is monopolistic and you're not allowed to, inhibit his right to practice. But I mean, you must be somewhat, as a doctor who works as a cog in a large machine, you must run up against, bureaucrats that are far away from what you're doing at the bedside, who don't understand and are not as able as you are, who's sitting managing an ICU, managing an ICU. Like, better what you need, in a way that somebody far removed from the situation does not. So this insulation of all these places, it seems like you have a tremendous amount of faith in these, bureaucratic folks to make these decisions about to make decisions about allocation of resources well. And I can't imagine. I don't have that, and I can't imagine you have that. And I don't
know. I don't think it's that hard. You decide that a community needs a fire department, right? So who's the godlike entity that decides that only one fire department is needed? It seems to work pretty well. Are the places?
Right, but we don't have a national fire department.
No, but you have municipality, public. You do not have a private sector of competing fire departments that people pay out of pocket, and with price equilibration determining the optimal allocation of resources and the optimal allocation of firefighters. You have municipalities that set up publicly paid, global budgeted fire departments that get a lump sum and spend that money in the best way possible. People would hate it. People would think you were nuts if you wanted to move to a totally free sector of firefighters that you pay a point of service for fire needs. And I think close to healthcare in many ways. I just don't imagine what this price equilibration system would work like in most of the healthcare that I see delivered. And in any event, I think you can plan out where an ICU is. If I want to build a 200-bed ICU down the street in Cambridge, it may not make any sense, So maybe that it is okay to have a government regulators say, actually, Adam, this place already is stock full of ICUs.
But Adam, what if that 200-bed ICU can do what your ICU does for 1/10 of the cost?
Then regulate the cost.
How does the government regulate
the prices?
No, but how does the government regulate? See, our distinction is on price. We both agree that healthcare, at least I agree. I don't want to speak for Michelle. I totally agree, Adam. Healthcare, the prices in healthcare are ridiculous, right? And that seems to be most of the problem. There's a paper out by Ashish Shah and colleagues about how, yes, it's not utilization that is the big issue. That is the massive issue. Yes, there's more utilization than other places, but that isn't necessarily the driver of why it is healthcare costs so much. And that's where, but the issue here is why do you trust folks to get the price right? What if you can get even cheaper than what Medicare is doing, right? Look, the problem is that in every single third party heavy payment, whether it be Medicare, let me ask you, is Medicare stable? Is traditional Medicare for all, is it stable going forward? It's not. Is it
far more stable than the alternative? If you were to put all seniors into private insurance,
but is Medicare right now? Meaning, is the trust fund? Are we able to fund this?
Increase taxes to if healthcare costs rise and healthcare needs rise, you may at some point need to increase taxes to maintain current level of spending for Medicare. That's possible. On the other hand, many of the predictions about Medicare cost growth have been modulated, or have shown to be somewhat things weren't as negative as people thought. But in any event, I mean, you have to think about these questions in comparison to the alternative. So, what's the alternative to Medicare? Well, alternative to Medicare is taking away Medicare and having people go to the private marketplace. And that's just not politically feasible because seniors will say that they want access to health care and they don't want to, be uninsured and go back to the pre-Medicare days when older people were, dying for lack of health care or not getting the health care they needed, or even forget that, we're just going broke. And that has been clearly, whatever you want to talk about the studies on how much health insurance improves longevity and whatnot, there's no question that it prevents people from going bankrupt or going broke. It improves, financial catastrophe. So, I mean, we can get into a philosophical debate about the best way to decide where hospitals are built. I think that this has been done. A lot of countries have the kinds of systems I'm talking about. They don't, they work pretty well. Again, you can look to Canada, you can look to many countries in Western Europe that have single payer systems that regulate the healthcare supply. We already do it for doctors, right? There already is a system of accreditation and of training that you have to go through. Yeah, we're not going to get everything perfect. And there may be places that could use some more hospital beds, maybe some places that can use fewer. But the private sector is not doing a good job at all. And I know you're not satisfied with the status quo either, but I mean, there's rural hospitals are closing. There's places that need help, that need hospitals that don't have them, and that we could fix that. And if the prices are the problem, then regulate the prices. I mean, that's what Medicare does. Medicare keeps prices down better than the private sector. We could do the same with Medicare-4-All and keep prices growing at a reasonable rate.
So let me ask you this. Medicare pays the same price to a wonderful doctor like Anish and to a completely incompetent
someone like me.
like myself. Or is that fair? Is that fair? I mean, if the government starts setting prices, the government has no idea who's good, who's bad. So there's no way to distinguish
we don't know
regarding a good hospital or a bad hospital or a good doctor or a bad doctor. Then you get into metrics. We're going to say, well, we're going to, Anish has to prove to me, the regulator, that he is good. So then Anish is going to spend more and more time, demonstrating that he is good. And we know how that goes. That's not a really good story.
I agree. I'm not a pay for performance kind of guy.
Right. So, but at the same time, I mean, if you're not, but there's no good alternative for the central organization to pay according to quality.
It gets to the fundamental one of the fundamental problems with getting this idea of healthcare as a right. One is, of course, defining what exactly healthcare is, and that's a problem for me. But also, when you say healthcare is a right, you then are automatically conscripting other folks to do something for you, right? Like, meaning, if somebody else is setting some price for healthcare, you're saying, if you are in healthcare, you must provide this service to him for this price.
I mean, that's what we do with public education. We pay teachers.
Yeah, it's not working very well, as far as I can tell.
I think public education has. There's always downside. There's always imperfections in every system. I think that overall public education has worked well in the societies that it exists. I think if you look back in the days before public education, people were much less educated. And I think that people like high quality neighborhood schools and would keep them.
Well, we certainly stamp people as being educated more today than we ever did before. Now, whether they're actually more educated, I mean,
I think education is higher now than it was in the 17th century. I don't really think that's
well.
Let's not go on a tangent. Actually, I think we need to wrap things up. But I want to ask one question to Adam. In your system, are patients and doctors allowed to opt out, or are they, as Anish said, do they have to? Are they conscripted into Medicare-4-All, or are they allowed to opt out of Medicare, and are patients allowed to opt out of the system?
So, I mean, those are details that will be ironed out further in the process. I think if you look at it in a place like Canada, there is in most countries with single payer systems, some, concierge type care that continues outside the system.
Not in Canada. In Canada, it's illegal to provide private.
You can't. My understanding of Canada is you can't take money. You can't have it both ways. I think if you exist entirely outside the public system and just give pure concierge care and don't take any money from the Canadian Medicare system, you can. The problem is once you start creating a sort of separate system for rich people, then you one of the key things about single payer, and I think that, going back to the issue of Greece and these, questions of do we want a sort of lower universal system that provides universally lower quality care? No, we don't. And this is something that Bevan understood when he helped create the British National Health Service, that if you're going to do this, you have to provide the highest quality of care possible to everybody. You want world-class service, not, second.
Yeah, but Adam, it's not happening, Adam. Adam, the reason the NHS, I mean, look, Adam, your book, by the way, is fantastic. I had to get it to try to prepare for this, and it's a wonderful read. I urge everyone to get it, because it's such a I don't know how many hours you must have spent. You're clearly an incredibly well-read guy in terms of the history of healthcare, and it's really, really, really good. But one of my things that I'll say that you didn't seem to get into is how exactly these systems are working. Like, I mean, I'm with you, man. I want to provide healthcare to everyone in the country, right? I want, if somebody has an injury, I want them to get care. If somebody has hypertension, I want them to be able to walk into some local doctor's office and get care and prevent their heart failure and their heart attack down the road. So I'm totally with you. But look at how the NHS, for instance, look at how the NHS actually ends up delivering care, right? We just had Saurabh Jha, a Rograd, on to talk about the case of Bawa Garba. And Bawa Garba is a pediatric trainee who was working in one of the tertiary care hospitals in the United Kingdom, right? And again, I'm not going to go into the case of Bawa Garba and what happened to her, but the way the NHS is set up in terms, you're talking about world-class care, right? You have one PGY4 running 3 different wards, admitting patients in the ER, doing lumbar punctures, and running and responding to codes. Adam, I think you have misplaced faith in the ability of, I hate the cliche, central planners, but I have to come up with a better one. But you have misplaced faith in their ability to allocate resources correctly to deliver care to patients. I think, and it's true in all of these different systems. Yes, you can walk into any place in the UK or Canada and you get $0. That's great. But when you actually peel back a couple layers and look at how exactly the UK, Greece, Italy are delivering care, you have a tough case to make to say that you're not going to degrade care if we switch to that type of system here. I understand you don't want to go. Well, I understand now that you don't want to go from 17% to 11% of GDP. You want to keep it here, or even maybe go higher. But the issue is that as soon as you, for whatever reason, these systems create a class of folks that are just not as productive. I don't know. I don't know how else to explain it. Why is it that the NHS, a tertiary care hospital in the NHS, is staffed in this way? That you have a PGY4 trainee. There's no attending in the house, right? There's just one PGY4 trainee running 3 floors, barely able to get to the ER. You had a patient that had a bad outcome that I don't think was her fault, but it's not a good system. So I don't understand how we don't have a good working example of what you're talking about. So why should we go to it?
I think that, first of all, the NHS has had a squeeze on its finances in the last few years, more than that has severely strained the system. So yes, you have to, they're being too parsimonious. You have to fund these systems adequately. If you look at the metrics overall, I mean, just looking at the numbers, these systems do work better than ours in terms of achieving reductions in amenable mortality, healthcare mortality that's actually responsive to medical care. And if you look at the Canadian system, not so far away, I think that overall people are very happy there with the healthcare they get. Imagine being able to live your whole life, not worried about your insurance plan, not worried about your deductible, to get any care you need at any time, and never have to worry about the cost or worry about whether you are going to go bankrupt, and just focus on your illness. I think that's a huge good that I think that you're not giving sufficient emphasis on.
The psychological...
Yeah, and psychologically, absolutely. I mean, it can be a horrifying affair as a patient to be dealing with a stage 4 cancer, while at the same time you're wondering how much your ICU stay is going to cost, or your MRI or chemotherapy. So I think that has a huge psychological benefit. I think that the systems work pretty well there. I think they're not perfect. There's no perfect system. There's no medical utopia, but I think we can do a lot better job. with a public system that guarantees it for everybody, rather than the hodgepodge public-private mix that's dragging everybody down.
But
Adam, I'm going to let you have the last word here.
This is going great. Who says? Who says?
I don't know. Anish, did you have?
Part two.
I'll notice. Part two is probably good. This is a wonderful conversation. But Adam, you keep saying that all of these systems, whenever I point out the ills to them, you say, well, we just have to fund them better. How would you fund the Greece system better? That's not, you make it seem much simpler than it actually is, correct? Like, where do you get funds to fund the Greece system better?
Taxes.
So you want to, sell that to the Greeks in terms of raising taxes even more than who are you taxing? They're barely, like 40% of the population is like not working. There's systemic issues. There's systemic issues to doing this, right? Meaning that
UK should increase tax. It's very simple. The UK should increase taxes and increase spending on the National Health Service.
With that, I think we'll let it go.
Well,
thank you very much for joining us.
All right, thank you for having me. I enjoyed the conversation.
And on the show notes, I'll link to your book, your website, and any other important papers that you've written that you'd like our audience to have access to.
All right, thanks for having me, gents.
Take care.
Absolutely. Alrighty, thanks so much.